Hello all. We're going to talk about the nutritional concepts in med-surg nursing, but I understand that you have already had nutrition. So many of these concepts you already know. Many of the definitions you should probably already know. But we're in chapter 55, and this starts in your textbook on page 1195 in the 10th edition. You'll notice starting on page 1195, there is a lot of key terms that are in blue, and they're also inside your chapter within the reading in blue. And just make sure that you are looking at those definitions and those terms. So here's some key concepts. How do these relate to nursing care that we give to our patients? Why is it important for healthcare professionals to exemplify optimal nutrition, both in regard to themselves and their patients? Like, why do we need to exemplify nutrition? Besides carbs, fats, and proteins, what other nutrients are essential for our health? How does nutrition relate to physical activity in terms of homeostasis? So key concepts here: optimal personal and community nutrition, a major component of health promotion. Certain nutrients in food are essential to our health and well-being. And just like I said, we have carbohydrates, we have proteins, we have fats. Those are essential. Those are macronutrients. We also have micronutrients such as the vitamins and minerals, vitamins that are water soluble and fat soluble, and also minerals such as iron, calcium, etc. So you already know many of these things. So in all activities and all we do, our body attempts to meet the calorie requirements, even if it's at the expense of proteins within our body. So when the calorie intake is insufficient, our body uses proteins for energy. And you will see that sometimes in your patients when they don't have enough nutrition while they're in the hospital even, but many cancer patients have what's called cachexia, and you can tell that their muscles are wasting and they, basically are just skeletons sometimes. People who have anorexia nervosa, true anorexia nervosa, have lost a lot of weight and lost their muscular mass and their protein. And just think of all our body is made of a lot of protein. So not only your skeletal muscle, but you have to think of your other muscles such as your heart and your diaphragm. So people who have wasting of or use their protein for nutritional energy expenditures, or energy needs, I should say, they may have heart problems or even breathing problems because of this. So good nutrition is essential to good health. So why is nutrition a component of health and wellness? Well, again, we need to eat to maintain our proteins, to maintain our fats. Some people think cholesterol is all bad as a fat, but we need, all our cells contain cholesterol, and we need cholesterol in our diet, even though our liver does make some. But we do need proteins, fats, and carbohydrates are our main source of energy. So what other uses are there of food other than to satisfy hunger? You probably can think of not only satisfying hunger, but some people think of foods as a comfort. Some people use food products as skin products. You know, avocado, cucumber, tea. You can think of foods in that way as well. How do nutritional requirements change during a person's lifespan? Most people, as they age, need different requirements. They have different needs according to maybe they've developed some type of chronic illness or other health problems where they need different, and take medications where they need to alter what they eat or what they intake. So if a person's malnourished, how does that affect his or her functioning? Well, again, like I mentioned, the heart and the lungs. If people cannot eat, they tend to lack energy, so don't want to get up and do anything. So again, good nutrition, essential to good health. Health has to include meeting basic human needs. Wellness seeks the full development of potential for all people. How can a nurse incorporate nutritional science and education into a plan of care? You know, that's something that if your patient is not eating, or maybe they're eating the wrong foods according to their chronic illness, you know, people who are diabetic, for instance, you know, maybe they shouldn't eat a bunch of sugar. Or people who have congestive heart failure shouldn't be eating a whole lot of salt. So we have to look at it in that way as well. So good nutrition is essential to good health throughout the life, prenatal life through old age. Wellness implies a positive, dynamic state motivating somebody to seek a higher level of functioning. So wellness is not only our physical, but also spiritual, social, psychological. So all those things encompass health. So it's not just the absence, health isn't just the absence of disease, and wellness certainly is not. So we do have national health goals that when I started teaching back in the late 90s, they had a Healthy People 2000. We have not met all of those goals, but we continue to make goals in order to meet that, you know, try to meet them. So national health goals are in a response to medical care systems focus on illness and disease. Some medical people would like to get away from that focus on health and disease, illness and disease, and would like to focus it more on health promotion. These national goals are also a response to our rising healthcare costs. You know, we want to keep people healthy instead of just trying to cure them when they get sick. And the national health goals also focus on lifestyle and personal choices. So now, not only did we have a Healthy People 2000, we had a Healthy People 2010, Healthy People 2020. We've passed that up and have not met all those goals. So now we have a Healthy People 2030. And here is a goal, one goal, to improve health by promoting healthy eating and making nutritious foods available. But this is something I want to show you that is rather prevalent different places in our country. Not likely necessarily that it's in other countries, but this is a picture that I got from the internet. I've never been to this place, but this is in Clearfield, Pennsylvania. And this humongous hamburger, this is a real thing, was concocted by the chefs at Denny's Beer Barrel Pub. The burger might help the pub defend its Guinness Book of World Records status as the restaurant with the world's biggest hamburger. So Denny's big burger lineup includes a 2-pounder a 3-pounder and a 6-pounder. If you can eat the 6-pounder in under 3 hours, you get the burger for free, along with a commemorative t-shirt and your names on a wall of fame. So far, the only winner has been a 100-pound female college student. Owners thought a 15-pound burger would attract more customers and be a good option for families, parties, and anyone who would be up for the challenge. So the challenge is simple. The person just has to polish off the newest monster burger in under 5 hours, and you win $350, a t-shirt, and your name on that wall of fame. So you also get the burger for free, which is not bad, considering that it costs over $40. Fries are extra. So the newest burger is dubbed the Beer Barrel Belly Buster. It's as big around as the inside of a car tire and should be approached with relish. A cup and a half of relish, that is, and probably a cup of ketchup and a cup of mustard too, and a cup of pickles and all those other things. A head of lettuce, 2 onions, 3 tomatoes, 25 slices of cheese. That's what's on this thing. So this is not healthy, do you think? So all of the ingredients that are in this thing are enough beef to make 70 McDonald's quarter pounders. So that's a lot. That's a lot of food. And it is a real place, so you can look it up online if you would like to. But yeah, so we don't have to worry about other things. We need to worry about who's trying to destroy our health in this country. So there are kind of shifting gears here. We want to again prevent diseases. That hamburger doesn't help, but there are traditional ways and preventative ways. So the traditional ways to manage health is to, cure people or try to help them only when they're ill or when they get a disease. And really, that's not a very positive approach to healthcare. So a better approach would be a preventative, which identifies our risk factors and tries to help people choose behaviors or modify their behaviors to minimize their risks of disease. So the nutrients already mentioned: carbohydrates, proteins, fats, vitamins, minerals, and of course, we would not be living without water. Have to have water. So some different functions of nutrients. Each individual person or each individual nutrient has a specific metabolic function. So we have to know what those are. No one nutrient ever really works alone. Most of these we have to have water or some other substance to help us absorb or use them. So function of nutrients, again, provide energy. And the ones that provide energy, again, are carbohydrates, fats, and proteins. They build tissue, regulate metabolic processes. Again, no nutrient ever works alone. Individual nutrients have many metabolic functions. So there's our energy sources. Carbohydrates are the primary source of fuel for heat and energy, and also means the body's backup store of quick energy is glycogen. Remember that word glycogen, which is sometimes called animal starch, and it is stored in our liver. Human energy is measured in heat units called kilocalories, and each gram of carb yields 4 kilocalories of body energy. And the 4 calories is called its fuel factor. In a well-balanced diet, carbs should provide about 45 to 65% of total daily kilocalories. Fats come from both animal and plant sources, and they provide a secondary or storage form of heat and energy. Fat is more concentrated, and it yields 9 calories for every gram consumed, and thus has a fuel factor of 9. In a well-balanced diet, fats should provide no more than 20 to 35% of total calories, with most of that being from unsaturated plant sources. And I'm sure you learned about that in nutrition. What is unsaturated, what is polyunsaturated, monounsaturated. Those are typically plant foods and supposedly better for you than saturated fats, such as animal fats. Proteins yield 4 calories per gram, and so their fuel factor is 4. The body, again, will use protein if there's not enough carbs and fats consumed. So somebody who isn't eating, somebody who's anorexic, somebody who doesn't just feel like eating will get thinner and thinner and lose muscle mass if they are not eating carbs and fats. So in a well-balanced diet, protein should provide about 10 to 35% of total calories for that person. Proteins are for tissue building primarily. Dietary protein provides amino acids. Don't forget that amino acids are building units for construction and reparation of body tissues. So somebody who's had surgery and actually been has had an incision needs to have a reconstruction of their tissue and repair of their tissue. So they need increased amount of proteins in their diet. So tissue building is a continual process that ensures growth and maintenance of a strong body structure and vital substances for its tissue functions. Vitamin C is another tissue builder. It prevents bleeding, helps prevent bleeding, and helps us form collagen. That is a structural unit that keeps our body structure, and you can tell when people lose collagen because they start getting wrinkles. Calcium and phosphorus build and maintain bone tissue. Iron contributes to hemoglobin. Fatty acids help build the central fat substance of cell walls and promote the transport of fat-soluble materials across the cell wall, such as vitamins. Food and nutrients guides help us to plan a balanced diet according to individual needs and goals that we have. Because maybe some people want to gain weight, maybe some people want to lose weight, maybe some people want to build muscle. So there are such things as dietary reference intakes, and that depends on a person's age, gender, and life stage that influences the nutrient values. Dietary reference intakes are revised every 5 years. Dietary guidelines for Americans are another one. And again, this is just a guideline. I know you've heard of the choosemyplate.gov or myplate.gov, and this is kind of the simple approach to teaching people like what their plate should look like. So this is kind of helpful for just anyone. Nutritional status has been defined as an individual's health condition because it's influenced by the intake and utilization of nutrients. Poor nutritional status is not confined to malnutrition or undernutrition, because people who are overweight or obese also have a poor nutritional status. Nutritional status of an individual is generally dependent on 2 factors: external factors like food safety, culture, society, economic factors, and then there are internal factors: age, gender, nutrition, behavior, the physical activity of the person, and diseases the person has, whether they have an infection, any kind of stress, what are their eating behaviors, what are their psychological factors, and are they receiving any kind of drug therapy? So a lot of things go into planning for somebody's nutrition. So we need to identify nutritional needs of people based on whether they have any chronic illnesses, what are their food habits, food choices, food sources that they have, or maybe they have few food sources or resources. But food plays an important role in maintaining good health and recovering from illness. And in the slide, as you can see, one of the ways we assess a patient's nutritional status is even through looking at their lab data. You know, you can look at that fluid and electrolytes. You can look at their albumin level. So all of those you can look at simply by looking at their lab values. So here is a list of signs of good nutrition. And again, you've learned all of these probably in your nutrition class, so I don't need to necessarily go all over those with you. Healthcare planning. If you look at page 1198 in your textbook, there is a best practice for patient safety and quality care nutritional screening assessment. So again, not going to go through that, but I do want to point out that people who cannot swallow, can't chew, don't have teeth, things like that, yeah, they're going to have problems with nutrition and maybe a lot of weight loss. People with newly diagnosed problems, chronic illnesses such as Lou Gehrig's disease or myasthenia gravis, they can't swallow, so they may lose a ton of weight without anybody ever really understanding why. Like, why can't you swallow? What's your problem? So we really have to look at a lot of different things about people. On page 1199, you find this Nestle Nutrition Institute mini nutritional assessment, and this is just an example of what we look for when we assess somebody's nutritional status. Then a person that has individual needs. Every person has different taste. You know, some kids don't like broccoli and other kids love broccoli. Some children have very discriminating taste buds and will eat anything and enjoy lots of different kinds of food where other children might turn up their nose at it. And adults are the same way. So what are our tastes? What are our individual needs? What is our culture? What's our income and what kind of food resources do we have? What are our food habits? What's our living situation? What are our energy demands? In other words, how much food do we need to meet our calorie expenditure? Or maybe we don't have, maybe we live a sedentary lifestyle and don't have much of a expenditure of our calories. Maybe we don't need as many calories. And then what is our changing, we have a changing food environment. People used to live off of the land and garden and can all their own foods. Now there's a lot of processed foods. We eat a lot of fast foods. A lot of people eat out. And so we just need to know, what are people's food habits? Anthropometric measurements. Anthropometric measurements are non-invasive methods of evaluating somebody's nutritional status. So there are a lot of different types of anthropometric measurements. And the ones I really want to focus on here are body mass index. So in your book on page 1200, they talk about body mass index, and it says assessment of body fat is usually calculated by a dietitian if they're in a hospital setting. The body mass index indirectly estimates total fat within the body by relationship of weight to height. Therefore, an accurate height is important as an accurate weight. So height and weight both goes into that measurement. They have a couple of tables there, body mass index ranges. What I would like for you to do, I would like for you to Google a body mass index chart and look at that and find your height and your weight and find your BMI on that chart, just so you know what it is. And so you know what the numbers mean. So in table 55.2, below 18.5 of a BMI is underweight. 18.5 to 24.9, normal or healthy weight. 25 to 29.9 is overweight, and then 30 and above is considered obese. And then we have another category that is called morbidly obese, that is more than that. So here's an example of a body mass index chart. So you will be seeing this again, so you need to know those healthy weight, overweight, and obese numbers on this chart. So there's also something called body surface area. Body surface area is table 55.3. That's an estimate of a patient's total body surface area calculated as a two-dimensional measure of the person's body size. So it reflects physiologic and metabolic processes. So heat exchange, blood volume, size of organs, things like that. So something we use body surface area for, and you may have done this in pediatrics, they can use it for calculating medication dosing. Good nutrition. So here are some terminologies: optimal nutrition, undernutrition, malnutrition, and overnutrition. And just kind of read through what those are. So what I would like for you to know is protein energy undernutrition, and there are three types. Marasmus is a calorie nutrition in which body fat and protein are wasted, but serum proteins are often preserved. So there's enough protein in the blood, but there is a calorie malnutrition. Calorie malnutrition of protein and fat. Kwashiorkor is a lack of protein quantity and quality in the presence of adequate calories. So marasmus, not enough calories. Kwashiorkor is plenty calories, only not enough good protein. With kwashiorkor, body weight is more normal and serum proteins are low. Whereas in marasmus, serum proteins are preserved. Starvation is a complete lack of nutrients. This problem can happen even if there is food available, but it's most commonly seen in areas in which food is unavailable. But I again want to point out that sometimes if a person remains undiagnosed with some type of chronic illness where healthcare providers cannot figure out what it is, people can literally starve and lose a ton of weight. So just remember, like, what are some causes of this malnutrition? That's what I'm trying to get at. What are some of these causes? We think a lot of people in third world countries, you know, who don't have food supplies as starving or having marasmus or kwashiorkor, but that can happen to anyone who remains, you know, undiagnosed possibly, or has cancer or any other type of illness. And again, complications I talked about before, heart failure, liver failure, kidney failure, any kind of thing like that. And it's some kind of a chronic problem. So the nursing process in malnutrition, again, we want to do a good history and physical assessment, and even a psychosocial assessment to see, you know, are these people under stress? What's their culture? Where do they get their food? Do they have enough resources, etc.? And then always look at their lab values. You can always make a nursing diagnosis based on what you assess, and if you find a problem, you can, of course, make that nursing diagnosis, plan what you're going to do to improve that problem, and then implement whatever interventions you come up with and do those, and then evaluate if what you did helped or not. I want to kind of point out something else with starvation, kind of going back to that. In your book, it says unrecognized or untreated PEU, which is, again, protein energy undernutrition. Acute PEU may develop in patients who were adequately nourished before hospitalization but experienced starvation while in a catabolic state from infection, stress, or injury. So again, where do we get these problems? You know, patients who are NPO for long periods of time can go through periods of quote-unquote starvation. Then we have other problems such as eating disorders, anorexia nervosa, bulimia nervosa, binging and purging. And I want you to know what anorexia nervosa and bulimia nervosa are. Anorexia nervosa is self-induced state of starvation resulting from a fear of getting fat. But most of the time, those people are underweight, but they look at themselves in the mirror and see someone who is fat. So therefore they starve themselves, they will not eat. I have seen one and taken care of one truly anorexic patient in my life, and she was nothing but a skeleton with skin over it. And her heart was failing, her kidneys were failing, her lungs were failing. There's absolutely nothing we could do for her. And even like trying to put in a feeding tube, she would reject that food. Like her body would just reject that food. So very interesting. But anyway, sorry, I went back to that starvation point. So we get into enteral nutrition. So what is total enteral nutrition? Total enteral nutrition is if a person can't intake foods orally, we do total enteral nutrition, or TEN. So it may be needed if that patient can't achieve adequate nutrition, can't eat, can't swallow. So patients who are likely to receive total enteral nutrition can be divided into 3 groups of people. Clients who can eat but can't maintain adequate nutrition on their own, clients who have permanent neuromuscular impairment and cannot swallow, clients with a non-permanent neuromuscular impairment who cannot eat because of their condition. So possibly people who have had a stroke, perhaps that is not a permanent condition, and they can do therapy to restore their musculature to swallow, etc. But the permanent neuromuscular disorders, and I have Stephen Hawking here, he had Lou Gehrig's disease, or amyotrophic lateral sclerosis, same thing. Then there's myasthenia gravis. And then there are clients who can eat but can't maintain their adequate nutrition on their own. So types of feeding tubes. A nasoenteric tube. There's nasogastric, nasojejunal. So nasogastric is just what it says, goes through the nose and into the gastrum or into the stomach. Nasoenteric tube is a feeding tube inserted through the nose, and then it's advanced into the GI tract. One of those tubes is called a Dobhoff tube. You may have heard of that before. So nasoenteric tube, again, either a nasogastric tube, nasoduodenal tube. Then there are enterostomal feedings. And you may have seen these in pediatrics or not. The right upper picture is a cutaway and side view, so you can see how the tube goes into the stomach, and it is held in the stomach by some kind of device, whether it be a balloon or a plate of some sort. But those enterostomal feeding tubes are, they are used long-term. So they're put in people who need them for a long-term use. They put them in under sedation in the, they can put them in the GI lab. So a gastrostomy, there's a stoma created through the abdominal wall, and then they put the tube through that. And we call that peg tube when it goes through the skin. They can also put a peg J tube in, and that goes into the jejunum for long-term feedings. So maybe sometimes we would need to bypass the stomach. Maybe even somebody's had their stomach removed, so they would have a jejunostomy tube. So tube feedings, then you can see the girl in the right lower picture. She is giving herself a bolus feeding. So bolus feeding is an intermittent feeding of a specific amount of a product at a set interval in a 24-hour period. Usually they give themselves a feeding, or nurses give them a feeding every 4 hours or so. So this is manually. This girl is given her tube feeding manually, but you can also do it on a pump or a controller. Continuous feeding is similar to an IV therapy pump, like the pump is continuously giving a infusion by either a pump or gravity even. And then there are cyclic feedings, where they're the same as a continuous feeding, except the infusion is stopped for a certain amount of time in a 24-hour period, usually about 6 hours or longer of downtime. So again, bolus feedings, continuous feedings, cyclic feedings, or cyclic feedings. And there those are. There's a nurse or someone at home giving the feeding, again, through a bolus feeding. The upper picture is that's either a continuous feeding or a cyclic feeding. On page 1206, I want you to look at the best practice for patient safety and quality care. Tube feeding care and maintenance. You need to know this. This is a huge list, but you need to know these things if you're going to be given any kind of tube feeding. The initial placement of the tube should be confirmed by X-ray study. So you don't want to be putting anything through that tube unless you know for sure that it is where it needs to be, because you don't want to be putting it in somebody's lung. And you don't want to, you want to make sure that you didn't puncture something and be infusing it into the peritoneum. If gastrostomy or jejunostomy tube is used, assess the insertion site for signs of infection. Check and document residual volume every 6 hours or per agency policy by aspirating stomach contents into a syringe. So you always want to know how, are they digesting this stuff, or is it just staying where we're infusing it? Because we want them to be able to go through their GI tract. We want them to be able to digest it and to use those nutrients. Change the feeding bag and tubing every 24 to 48 hours. Label the bag with the date and the time of the change with your initials. Use an irrigation set for no more than 24 hours. So some of these, as you could tell in the previous, let me go back. Guess I can't. In the previous, like they were giving themselves a bolus. So those things are, many times that substance, it comes in cans. So label open cans with a date and time. Cover it and keep it refrigerated, just like any other food that you would keep. You can't leave it sitting out or it's going to get bacteria in it. Do not use blue or any other food coloring. People might be allergic to it and it might cause complications. To prevent aspiration, keep the head of the bed elevated at least 30 degrees during feeding and for at least an hour after the feeding. For bolus feedings, continuously maintain the semi-Fowler position for patients receiving cyclic or continuous feedings. And why do we need to keep that head of the bed up? Because it's a tube that is interrupting those sphincters, and the liquid can just come right back up and they could aspirate. So we don't want that to happen. Make sure you're monitoring lab values. Monitor for complications of tube feeding, especially diarrhea. There is an action alert there also. If a gastrostomy or jejunostomy tube cannot be moved while you're performing your regular assessment, notify the healthcare provider immediately, because the retention disc may be embedded in the tissue. Cover the site with a dry, sterile dressing and change the dressing at least once a day. So your priority for care of a patient receiving total enteral nutrition is to prevent and assess and manage complications associated with those tube feedings. One of the most common problems that develops is a clogged feeding tube. There's also a little box there, best practice for patient safety and quality care, maintaining a patent feeding tube. So you want to make sure that you, flush it with 20 to 30 mils of water, using at least a 30 cc syringe to prevent tube rupture. If you use a smaller syringe, you could definitely rupture a tube if you apply too much pressure. So you want to flush the tube at least every 4 hours. You want to flush the tube before and after medication administration, and before and after interruption of an enteral feeding. Do not use carbonated beverage or cranberry juice to unclog. And the best thing to use it is to unclog a clogged feeding tube is warm water. But those things are hard to get unclogged, I will tell you. Been there, done that. So, next thing on the agenda here is refeeding syndrome. So this is potentially life-threatening metabolic complication. And this is what happens, refeeding syndrome happens when we find somebody that is very malnourished or starving, whatever, and we decide that we're going to give them a lot to eat. So just so you know, that's not a good idea. Refeeding syndrome is a potentially life-threatening complication related to fluid and electrolyte shifts during aggressive nutrition rehabilitation of patients in a state of starvation. So it's not a good thing to just pile on food on people who are not used to having it. In your book on page 1207, Critical Rescue under Nursing Safety Priority, recognize signs of refeeding syndrome. This is very important to know this, which include heart failure, peripheral edema, rhabdomyolysis, seizures, and hemolysis. Lab values indicate hypophosphatemia, so a low phosphorus level, and hypokalemia, a low potassium level. Respond by contacting the healthcare provider immediately. Again, this could be life-threatening, so you don't want them to get into any trouble. So other complications of total enteral nutrition, tube misplacement and dislodgement. That is a big deal if you have somebody who is semi-conscious and their tube becomes dislodged and they're laying there. You have to understand that they can easily aspirate if that tube is misplaced and maybe migrates its way up the esophagus or whatever. They can easily aspirate. So you need to check those people right away. If they are not passing this nutrition through their GI system, their abdomen could become distended, they could get nauseated and vomit, and again, that could cause aspiration. And then we already talked about some fluid and electrolyte imbalances, and one of the problems with these tube feedings is diarrhea, and again, they can easily have electrolyte imbalances from diarrhea. So stepping away from enteral nutrition and going to peripheral IV type nutrition, we have peripheral parenteral nutrition and total parenteral nutrition. So just so you know that both of these are very hypertonic solutions. So they have to be administered through a large vein. Peripheral parenteral nutrition is administered through a large distal vein of the arm on a short-term basis. It's usually used for people who can eat, but they're not able to take in enough nutrients to meet their needs. It's fat-based. So it has an osmolarity lower than conventional parenteral nutrition. So it has less osmolarity than total parenteral nutrition. So PPN again, can be delivered through a big vein distally or through a PICC line. So it's more isotonic, but TPN is hypertonic. And so they have to be administered through a infusion pump. The patient requires intensive nutrition, and that is why they are getting it. So these people get a central line. It has to be delivered through a central line. And central lines are like subclavian veins or jugular veins. Those are central lines. Or they can have another type of line inserted like through their chest wall. Something like an example I know of is Grosjean or a Hickman catheter. Perhaps you've heard those terms. So the osmolarity of the fluid and the concentration of this components make controlled delivery essential. So again, it has to be given through an infusion pump. So lots of glucose in this, lots of protein, and then they also give a special bag of fat called liposine. Potassium and sodium imbalances are common when giving TPN. Calcium imbalances, particularly hypercalcemia, are associated with TPN. In your book on page 1208, again, our best practice for patient safety and quality care and maintenance of total parenteral nutrition. Again, study this. Make sure that you know that we would, if we gave somebody TPN that has tons of dextrose in it, that we would be doing finger sticks and we would be administering insulin as ordered. If a TPN gets behind in administering it on a pump, we don't set it so that we will speed it up. We need to maintain it. We should not be increasing the rate. Monitor serum electrolytes and glucose daily, at least. Change the IV tubing every 24 hours. We don't want to let it sit there any more than 24 hours because that is how bacteria, that's how we make people sick, is not to change things on time because bacteria love sugar. Before administering TPN, have a second nurse check the prescription and solution to increase patient safety. I don't see a lot of people doing that, but again, that is just something else to make people safe that we care for. So obesity and overweight, you're doing a discussion board on this, so I'm not going to go too much in depth about this because I think you'll learn a lot about it just by doing the discussion board. Just so you know how we define overweight versus obesity. So again, looking at the BMI of people. Almost 2 out of every 3 adult Missourians are overweight or obese. So again, this is why it's important to study this, is because if you stay in Missouri or pretty much almost any state in the United States, there tend to be, overweight and obese people. So obesity impacts both genders and races, all ethnicities, all socioeconomic groups, adults and children. This is just a map. I don't know how well you can see it, but it is a map showing the prevalence of obesity in our states. So all states and territories had more than 20% of adult with obesity. So once obesity is present, the number of calories consumed must exceed the energy expenditure for the condition to continue. In other words, if somebody wants to continue to be overweight or obese, they continue to consume and exceed the food they eat. If they want to lose, it's the opposite of that. So there are environmental and genetic factors in making people obese or overweight. Hormones are implicated, sedentary lifestyle, and socioeconomic status. Okay. So we're not going to go through that. We're not going to go through that. There are a lot of complications of obesity: hypertension, osteoarthritis, hyperlipidemia, type 2 diabetes, coronary artery disease, peripheral artery disease, stroke, gallbladder disease, obstructive sleep apnea and respiratory problems, and some cancers, and many other problems can be associated with obesity. And again, you're probably finding some of that out if you're starting to do your obesity discussion board. On page 1209, table 55.6, there are common complications of obesity. Here are some risks to becoming obese, just so you know. In your book, I would like to point out, this is actually on page 1209. It's talking about obesity being divided into 3 categories: class 1, class 2, and class 3. And just so you know, the distribution of body fat, rather than the degree of obesity, has been used to predict increased health risks. So even though somebody says, yeah, my BMI is 30, you know, which renders them obese, you know, where is that fat on their body? That is the predictor of problems. The waist circumference is a stronger predictor of coronary artery disease than the BMI is. A waist circumference greater than 35 inches in women and greater than 40 inches in men indicates central obesity. And something you need to know about central obesity is that it is a major risk factor for coronary artery disease, stroke, diabetes, some cancers, sleep apnea, and early death. The waist to hip ratio is also a predictor of coronary artery disease. So those things are important for you to know. So genetics is involved. Some people may be predisposed to obesity. Some people metabolize faster than others, or possibly some people have diseases that make them metabolize faster than others. There are environmental factors, and here are some listed. Psychosocial factors. Again, there is an emotional component to overeating. Stressors, boredom, social tendencies, cultural tendencies. So again, here we go again. Approach the patient with respect when you are assessing them. And what does respect mean? It's an acronym. Rapport for a safe environment. E is for encourage them to set realistic goals. Provide compassion, use tact. What's their economic status? Food intake, eating behavioral, cultural background, again, appetite, attitude toward food, what chronic diseases do they have, what drugs are they on? All of these things go along with assessing you know, how and why they are obese or have obesity. Another thing that you can use for assessment is a 24-hour food recall. And sometimes keeping a food diary helps people to lose weight. So again, I want to reiterate, don't forget the waist circumference and the waist to hip ratio. So if people have central obesity, they are apple-shaped. People who tend to carry weight on their hips and thighs are pear-shaped. Apple-shaped people tend to have those problems such as coronary artery disease and hypertension. But if we are helping people, we need to encourage them and tell them that even a 5% weight loss can drastically decrease the risk for coronary artery disease and diabetes. So teach patients that physical activity can be as simple as walking 20 minutes a day. So here's some things, again, here's some treatment plans that we can do. Nutrition therapy, and there's a lot of different types of nutritional therapy like Weight Watchers, Jenny Craig, etc., etc., etc. Exercise, and the exercise industry is huge. Behavior modification, again, learning how to not eat just because somebody is stressed or bored. There are support groups, there is drug therapy, and there are also surgical interventions. So the nutritional therapy, restricted food intake. So one thing that's really in right now is intermittent fasting. Low calorie or very low calorie diets. Again, a diet diary, eating habit discussions, setting goals, and discussing plateaus in weight loss. Daily weights are not recommended when people are trying to lose weight. Several small meals require more calories. Weigh food portions, that's one thing that people do, and also drinking enough water is highly recommended. Exercise is essential to weight loss. Produces more weight loss than dieting alone. So again, energy out should be more than energy in. So in other words, expending more energy than what they're eating. 1 pound of fat is 3,500 calories. So if you want to lose a pound of fat in 1 week, you have to burn or remove 500 calories a day per week, in the 7 days, and that equals the 3,500. So it says it's science, not magic, but it takes a long time. There are lots of different drugs that can be utilized, anorectic drugs, which are appetite suppressing, nutrient absorbing or blocking drugs, and glucagon-like peptides. Drugs will not cure obesity. So appetite suppressing drugs, phentermine, you may have heard of that. There's a lot of adverse effects because it has similar effects like an amphetamine does. So palpitations, tachycardia, overstimulation, restlessness, dizziness, insomnia, weakness, and fatigue. Appetite suppressors, again, here's a couple of them. You don't need to know these, unless you really want to check them out, but Belviq and Qsymia, which is the phentermine, but just make sure you look at the side effects of those. Suicidal thoughts and psychiatric concerns on both of those. Nutrient absorption blocking drugs. So on page 1212, I want you to look at that. There is a common examples of drug therapy for overweight and obesity treatment. So orlistat is Xenical. and Ally, which you may have heard of both of those, but they block fat breakdown by inhibiting lipase. So fats are only partially digested and absorbed. Calorie uptake is decreased. So the thing with Xenical is that it will, it says in the book, teach that loose stools, abdominal cramps, and nausea can occur unless fat intake is reduced to less than 30% of the daily intake. The drug mechanism facilitates GI symptoms since fats are only partially digested and absorbed. So if somebody is taking this medication, they need to cut down their fat intake to not get those GI symptoms. So if they go back to the doctor who told them to take this, and they say, oh, I'm always having, I always have to go to the bathroom really fast, and I always have these terrible abdominal cramps, and I always have loose stools and spots in my underwear. Well, they're not cutting down their fat while they're taking the Xenical. So even though it helps carry the fat out of their body, the person still needs to cut down their fat intake so they don't have these symptoms. So other fat suppressors, Contrave and Victoza, might have seen those advertised on TV. Sympathomimetics, and I already mentioned phentermine, and again that basically speeds everything up, speeds the metabolism. These are very popular right now, glucagon-like peptides. So Mounjaro, which is Zepbound for weight loss. It decreases appetite, promotes weight loss, and it's used for shedding weight, and it has become increasingly popular. And I have an FDA-approved weight loss drug there. It's like a little timeline from Xenical in 1999, and we are up to Mounjaro these days. So that is where we have been, and that's where we've come. Then there's behavioral management, and there are a lot of different, like counselors, support groups that can help with behavioral management. And then there's also complementary and integrative health ways to try to lose weight. Surgical management. So patients who may be candidates for surgical treatment include those who have reported failure of non-surgical intervention, repeated failure of non-surgical interventions, a BMI equal to or greater than 40, weight that is more than 100% above their ideal body weight. On page 1211, just a term that I want you to know. You may hear people say, or maybe you would see it in somebody's electronic health record, the term PANAS. PANAS. If you look on page 1211 in the first column, right under physical assessment signs and symptoms, it says, examine the skin for reddened or open areas. Lift skin fold areas such as pendulous breasts and abdominal aprons. And that is called, the abdominal apron, like the hanging down fat part, is called a paniculus. Some people abbreviate it in an electronic health record, or even when they're speaking, they call it a PANAS. So just so you know, people who have a paniculus can get yeast infections under it, etc. So watch for those infections, because the infection is called paniculitis, and they may need to have some kind of antifungal. So these are people that, again, might be considered candidates for surgical management of their obesity. Patients who have repeated failure of non-surgical interventions, a BMI equal to or greater than 40, weight more than 100% above ideal body weight. I've said that twice now, so I bet you'll see that again. So what do we call surgery for weight reduction? This is bariatrics, which is a branch of medicine that manages patients with obesity and its related diseases. Most patients have minimally invasive surgery by having either the laparoscopic adjustable gastric band or laparoscopic sleeve gastrectomy. Both of these are restrictive on then what the person eats. The decision of whether a patient is a candidate for the minimally invasive surgery is based on weight, their body build, their history of abdominal surgeries in the past, and any kind of coexisting medical complications they may have. Patients have to agree to modify their lifestyle and follow stringent protocols to lose weight and keep the weight off. And we'll talk about that in a little bit because they are very restricted to the food intake that they have. After bariatric surgery, many patients no longer have complications of obesity, such as diabetes, hypertension, depression, or even sleep apnea. So it's really can be a good thing for people. Just remember that surgical procedures, if they are taking out pieces of gut or stomach, people are going to have interference with food nutrient absorption from the GI tract. So they may have vitamin deficiencies or not be able to absorb nutrients, or because they are not able to absorb nutrients as they used to be able to. So restrictive surgeries are vertical banded gastroplasty, which restricts food intake by partitioning the stomach into a small upper portion. So it drastically limits the capacity of the stomach. So there is also delayed emptying of the stomach. The gastric band that is put around the stomach is adjustable. There are pictures on page 1215 in your book of vertical banding gastroplasty. So you can kind of see what that looks like if you don't know what it is. Malabsorptive surgery, gastric bypass is an example of this. So it's used in treating people who are morbidly obese, and the stomach is stapled to create a 30 to 45 milliliter gastric pouch. So again, very restrictive. If you look at the, again, the picture on page 1215, they have several different pictures of gastric bandings and gastroplasties. And I want to look particularly at what's called the Roux-en-Y gastric bypass. Let me see if so if you look at all of those different I want to say anastomosis. What is an anastomosis? Do you know? An anastomosis is anywhere where something is sewn together. So if you look at that Roux-en-Y gastric bypass, look what they have done. They have made the stomach very small and then stapled it. So there's just a small pouch. It says 20 to 30 milliliter capacity. That's very, very small. Then they they completely bypass the duodenum. See the stomach there, and they bypass the rest of the stomach. They pass the duodenum, and they take the jejunum and they sew it to, you know, the end of another portion of the small bowel. So they're bypassing the stomach. So the thing is here, not only did they bypass the stomach and the duodenum, but it's limiting the absorption, though. So this is why it's called a malabsorptive surgery. So these are the types of people who have this surgery that are going to get maybe some nutritional deficiencies. So if you look at that, you can kind of see that. So with these restrictive surgeries, these gastroplasties or gastric banding, I want you to know that the primary expected outcome is that the patient consumes appropriate, nutrient-dense foods to meet their metabolic demands without overeating. I mean, with a pouch that is as big as, it's 20 to 30 milliliters, so that is 1 ounce. That is one of those little plastic medicine cups. That is their capacity of their stomach. So that's all they can eat at any one time for a while. So just keep that in mind. They can't eat, so they're going to lose weight. So also, when you look at the picture on page 1215, again, I wanted you to look at all those anastomoses. We have to remember post-operatively that those places are all sewn together, so they can leak anywhere. So a leak of digestive juices and partially digested food can come through those anastomoses. So we have to be really cognizant of what complications there could be associated with these procedures. So preoperatively, the primary role of the nurse is to reinforce health teaching and prep for surgery. Most of these people who have this type of surgery will go through some kind of psychological evaluation before they ever have the surgery. Anybody who's going through surgery has an increased risk of that surgery because they are obese. So keep that in mind as well. More pre-op care, again, psychiatric, social stability, willingness to cooperate with follow-up care. This big, huge surgery with enormous numbers of complications that could occur, we don't want people to enter into any kind of surgery like this lightly, because things can happen. So that's why they usually have them agree that they're going to follow what the doctor tells them. So again, operative procedures, we just looked at those all on page 1215, and again, this is all called bariatrics. Again, the most common bariatric surgery performed in the United States is that Roux-en-Y gastric bypass procedure. And that one is done robotically many times, but it's just basically, we just call it gastric bypass surgery. But the weight loss is very quick. But this, again, when you look at that picture, look at how invasive that is and how much of a risk that presents for the patient. So again, lots of complications can occur because of that. So sleeve gastrectomy, and there's the Roux-en-Y again. And just look at all the staples, all those are anastomoses. These are the pictures on page 1215. They may not be exact, but they are very similar. Oops. So care depends on, what kind of surgery they had. But just so you know, after these surgeries, clear liquids are introduced slowly if the patient can tolerate water. 1 ounce cups are used for each serving. And so that right there, that picture, that is it. That is what they can take at first. A full liquid diet follows tolerance of the clear liquid diet. And usually patients are discharged on that, on a full liquid diet. Pureed foods follow in about a week, with each meal consisting of about 5 tablespoons of food. So just think about how much you eat at any one time. I'm pretty sure I eat more than 5 tablespoons of food at a time. So even though the stomach is very small, I don't know if they get hungry because their stomach is so small. So post-op. So this would be once they get out of surgery. The biggest worry for us would be their respiratory status. Again, anything that has anything to do with face, guts, we need to protect the person's airway. People also need to know after this procedure that bowel changes are common. Vitamin and mineral supplements are prescribed after surgery, especially vitamin D, B complex, iron, and calcium. So people need to make sure that they take those supplements because, again, they have malabsorptive surgery. So the greatest rate of weight loss during the first year after bypass surgery. The weight stabilizes after 18 months, and then there again are complications. Anastomotic leaks are the most common serious complication and cause of death after gastric bypass surgery. Vomiting, dilation of the pouch, rupture of a staple line, malnutrition, respiratory complications. So again, make sure you're maintaining your patient's airway. Make them do those incentive spirometers and deep breathe after their surgery so they don't get pneumonia. The last thing on here is called dumping syndrome. I think I have something maybe about dumping syndrome, but here's some before and after pictures. Very dramatic. So dumping syndrome is rapid gastric emptying. Bolus of food from the stomach, especially sugar, enters the small intestine too quickly. It's related to the food reservoir being removed and food entering the small intestines, like right away. It doesn't have time to go through the stomach and do any kind of breakdown. Most people develop signs and symptoms like abdominal cramps and diarrhea 10 to 30 minutes afterward. So prevent dumping syndrome by changing diet after surgery, such as eating smaller meals and limiting high sugar foods. So you will see dumping syndrome on the exam. So what is dumping syndrome? So here's signs and symptoms: diaphoresis, sweating, weakness, faintness, palpitations, and again it's related to a decreased plasma volume. They get nauseous, get diarrhea, their abdomen is distended, and cramping, and that's related to the rapid passage of food. So the goal, and we want to prevent dumping syndrome, is to slow the rapid passage of food into the intestines. So here are some things that people can do to stave that off. Eat low carb, moderate protein fat diets, drink fluids only between meals, not with meals. Eat small meals, and again, they have to be nutrient-dense foods in smaller quantities. They may want to take some anticholinergic meds before the meals, and they need to rest after meals. In more serious cases of dumping syndrome, medications or surgery might be needed. So home care, as you can tell by this, they just cannot eat a lot of food. Smaller portions, obviously, because they don't even have a stomach anymore hardly. They just have a little tiny pouch, sometimes only up to 100 milliliters, depending on what type of surgery they had, or where their band is. And again, those bands can be expanded and moved. Patients are usually followed closely by the surgeon and a dietitian for several years. And if their paniculus becomes more drapey, you know, they had that fat that was hanging down, and now they've lost the fat, but that paniculus is still there, they may undergo plastic surgery to have that removed after their weight is stabilized. So again, for weight loss, we want to ask a patient to keep a food journal, because that'll keep them accountable for what they're eating. Document their mood and events that take place when eating, because again, this can, overeating and obesity, overweight can all stem from stress and, you know, just things that are going on in life. Bowel changes are common after surgery. Vitamin and mineral supplements, again, are often needed after surgery because of the malabsorptive problems. And here are some health resources for people who are overweight or obese. And then that is the nutrition chapter. So thank you for your attention for nutrition. Thank you so much. See you or hear you again in a bit.